Okay, I think we are getting there. We may be live. There's sometimes a lag, so I'm just going to start talking. So welcome back, everyone that usually tunes in for the week, and thank you for taking a break from the Vikings game to watch us. And for those of you tuning in later on YouTube, thank you for watching this. So just a quick update on COVID. We usually do a little update right at the beginning, and we've had 2 more people in our community pass away from COVID. So I just want to acknowledge that and encourage everyone to keep looking out for each other and wearing your masks. We're up to 1,230 total cases so far in Carver County. So we're still climbing. So I want to introduce our 2 guests. We are joined by Representative Dr. Kelly Morrison and Senator Dr. Matt Klein for our conversation on healthcare, which I'm thrilled about. So if you guys want to take a second to introduce yourselves, go ahead.
Okay, I'll go first. I'm Kelly Morrison, and I represent District 33B, which is 10 communities in the Westlake Minnetonka area.
So if you guys...
Sorry, I'm getting feedback. Kind of right next to Addie Miller. And I've been a practicing OBGYN in Minneapolis for 19 years. In fact, September 11th is a stunning day for all of us. I lost a dear friend that day in those towers. We lost a lot of Americans and incredibly brave first responders. And that was oddly also the first day that I operated as an attending in Minneapolis. So that day holds all kinds of memories for me, as it does for all of us. But I was practicing medicine, raising my 3 children. I'm originally from Minnesota. I actually have really deep roots in our state. I'm a 6th generation Minnesotan, but I lived in other places. And so I feel that I have the perspective to appreciate what a great place our state is, and also how much better it can be. I had this creeping suspicion or sense of unease, I guess, about this growing suspicion, I should say, around science in our culture. And I didn't really know what to do about that other than to debunk it one conversation at a time with my patients. And then the 2016 presidential election happened, and that campaign was so disheartening to me, and I was unhappy with the outcome. It really just pushed me to get involved in politics. My career has been in women's health, so there are ways in which I feel like I've always been involved in politics just because women's health can get so politicized, but I never had been in a formal way. And so after a lot of soul searching and some family votes, I decided to run for office and ran a really great campaign. I had a ton of wonderful volunteers and interns. We door knocked our district almost 4 times. And we beat a 3-term incumbent by 216 votes in a district that had never been held by a Democrat before. So it's been a tremendous honor to represent my district in the House. Our purple districts, I think, to me, they're hopeful because Democrats and Republicans and independents live next door to each other. Our kids go to school together. We go to church and synagogue together. We're friends. And increasingly in our country, that isn't happening. And we have to get there. We have to talk to each other and listen to each other. And so that's a little bit about me, probably more than you wanted to hear in the beginning, but I'm so glad to be here. Thanks for the invitation today, Addie.
Thank you. Senator.
Yeah, thank you so much. It's what a privilege to follow Dr. Kelly Morrison. And, this is one of those silver lining things that we've talked about so much with the various events that have happened in our lives. Obviously, the 2016 election was pretty staggering for all of us, and I think maybe traumatizing for many, but if it made Kelly Morrison run for the House and then win in that seat, then something good came out of it. So God bless that. So my name is Matt Klein. I grew up in St. Paul. I'm a practicing internal medicine physician at Hennepin County Medical Center. I'm what's called a hospitalist, which means I admit people from the ER who come up to the floors with, COVID or with diabetes or with heart attacks and so forth, and I care for them. I love working at Hennepin County Medical Center. I did residency there back in the 90s, and I now have been back there for 10 years. Obviously, we're in the heart of everything that's happening in America right now. Hennepin County Medical Center is where George Floyd died, and I work closely with the police officers, that come in every day and have a difficult job that they face, but also have, I think, some inherent cultural difficulties that need to be worked through. I chose to work at Hennepin County Medical Center quite purposely. because we care for everybody who comes through the door without regards to background or income. And I believe in that firmly. And that's what drove me in 2016 to run for the legislature. When I ran, there had not been any doctors in the legislature for 25 years, for a quarter of a century. When I entered, then there were 2, and then 2 years later, Dr. Morrison and Dr. Mann joined me, so we're up to 4. But 2 are leaving, so we'll be back down to just me and Kelly in a little bit here. It's been inspiring, and I've been really grateful, and I'm so hopeful that, obviously when I ran again in 2016, I assumed that being a Democrat in a safe seat running for the state Senate, I would enter in the majority. Since Democrats have been in the majority for the state Senate for the last, 90 of 100 years. But I was surprised that we were in the minority, and I've been in the minority ever since. But we're going to add Addie Miller to our Senate chamber next year, and we'll get back a strong majority. So thank you so much for having me, Addie.
Right. Yeah. Thank you both. So a lot of the folks that I talk to on the phones, and I talk about it all the time on here, know that I got into politics because of healthcare as well. My mom suffers from 2 at the time in 2016, and now 4 autoimmune disorders. And in 2016, during that, wild election, I was home visiting her and saw her healthcare bill on the counter for 3 months worth of treatments that she needs to keep active and healthy. And it was $20,000 before insurance. So I just thought that was, just criminal. And what are we going to do about it? And that led me to, get involved in politics. And here we are, a couple of years later, and I'm running, and still, we've got a lot of work to do. So I always talk about bringing experts to the table. I'm certainly not an expert on healthcare policy or health in general. So who better to have this conversation with than the 2 of you? So thank you so much for being here. So we'll take questions in the comments too. If anyone's watching, pop those questions in the comments. But just to get us rolling, we prepped a couple. So the first one, are there any similarities between your medical practice and legislating?
So I think we can take turns going first, if that's okay with you, Kelly. You went first.
Perfect. Perfect.
Yeah. So there are, and I think the biggest thing that you learn in medical school is you got to listen before you speak and learn before you declaim. And people who go to medical school generally think of themselves as pretty smart. So you tend to get a lot of talkers, but it's important to learn to stop talking and listen to your patients for 3 or 5 or 10 minutes, however long it takes. And when you finally open your mouth, you'll be much more wise. And that skill was certainly hard for me. It comes more naturally, I think, to Dr. Morrison. But it
I don't know about that.
an incredible asset when I got to the legislature. There's a lot of talkers in that forum as well. But if you actually stop and listen for an hour before you stand up and speak, you'll be the voice that's heard in the room, and you'll have a lot more to say. So that's been a good skill that's translated for me.
I would absolutely agree with that. I think that we are by profession listeners, and I think we can all agree that we could use more listening in politics. And I also think there are sort of some surprising overlap skills. We're not attorneys, most of us, and we're not trained debaters, but we are very used to collaborating with all different kinds of people and meeting people where they are. And trying to put ourselves in their shoes when we're coming up with a treatment plan, when we're trying to listen to their story. Most diagnoses can be made just from the history, not from the physical exam. That was a lesson from medical school that stays with me. People will tell you their story. And so we need more of that in politics. We need to be able to hear each other. We are shouting past each other so much today. And I think that those skills are important. I also think there's an element of when things get tense in a committee hearing or on the floor, everyone gets riled up. And I think there's sort of an unflappability about being a doctor. No one's going to die today. The stakes feel very high, and they can be high. But I think that we have a calm most of the time that I think that can help kind of just bring the volume down and bring the temperature down a little bit. So I think that it can be helpful as well. I remember door knocking and thinking, this feels so familiar, because you go to someone's house, you knock on the door, they open their door, they greet you, and then they tell you their story. It's very much like working in a clinic or an ER. So there are a lot of ways in which the skills do translate.
Yeah, definitely. Yeah, that's sounding very familiar to, clients that walked into, when I was training horses, clients that would walk into, a horse barn and tell us why they wanted to ride. I mean, kind of similar,
Yeah.
a little bit higher stakes in the medical field, but so how can we as a state change the face of healthcare? That's a tall order, but something that I'm sure you guys hear on the phones every day as well as I do. How can we change the face of healthcare to make sure that everyone has access and that those costs won't break the bank?
I'm going first, aren't I? That's a big question, Addie. And it's an important one. I think that when we talk about healthcare and access and affordability, we need to step back and think about the social determinants of health in this conversation, because we know that probably 10 to 20% of our health has to do with healthcare. The rest of it has to do with everything else in our lives. It has to do with whether or not we have employment. It has to do with whether or not we have stable housing, whether or not we have adequate nutrition, whether we're drinking clean water and breathing clean air. What's happening with education. All of those things are what really encompass health. So all of that has to immediately be in the conversation. None of this exists in a silo. All of these things overlap and intersect and impact each other. But having said that, we do have the current situation of living through a global pandemic. Healthcare obviously becomes front and center. And I think that we've talked a lot about how the inequities that exist in our society that have been there have really been laid bare by the pandemic, and have pushed us to recognize that we have to make investments in public health. If we have a big segment of our population who is not healthy and who is actively not well, that hurts all of us. That's bad for all of us. And so on a small level, if you think about our grand American experiment where we can try things at the state level, I am one of those people who says, why don't we try the Minnesota Care buy-in as a way to experiment at the state level, as a way to increase competition, see if we can make it more affordable and get better coverage. We pride ourselves in Minnesota on our low uninsured rates. They have, depending on who's measuring it, they've crept up a little bit. And there's the reality of you have health insurance, but can you afford that insurance? That increasingly is out of reach for people. I'll say one last thing and I'll give it back to you, Matt. I sat on a panel at the Twin West Chamber of Commerce the other day with two executives from the Mayo Clinic and Allina, two of our big health systems and important players in our healthcare in our state. They both brought up the social determinants of health. They both acknowledged the lack of affordability. This is a huge problem that we have to tackle and get under control.
Great points about the social determinants, Kelly, as always. And there's a story that sticks with me. Every physician has 100 of these stories, and I think every Minnesotan has a couple of these stories, as you do, Addie. But there was a patient that came when I was on my night shifts, as I was running for the first time 4 years ago. A patient who came in, was about my age, he's about 55, and he was working two jobs. And he came in with some chest pain. He was a man, and he had chest pressure, and he described it in a pretty classic fashion. And we got an EKG, and his EKG looked a little worrisome, and so me and my partner, Matt, said, you've got to come into the hospital. We're going to give you some medicine and do some further evaluation here. And he said, no, I can't come in because I work and I have a shift starting at 1 a.m. And I also can't afford my deductible if you start ordering tests and hospitalizations and so forth. And I don't want to incur that cost. I have 3 kids at home. They have school in the morning, so we're not going to do it. And we were able to work together and call his employer and, explain things, encourage him to stay in, and he did stay in, and he had a good outcome. But it was one of those sort of watershed moments in my life where I thought, we live in this affluent country, and this is how we're treating human beings. He's being worked literally to death and is afraid to do the basic things that he has to do to survive and to remain a good father for his children. We're just a better people than that, and we have the resources so that things like that don't happen. There are solutions in terms of sort of expanding care to everyone, which is the dream. We do have to be thoughtful and judicious about how to balance that with costs, because currently our costs are driven by profit and are escalating too rapidly. And I think the public option that Kelly Morrison described is a great idea. I also am going to be working on something that will change the incentive flow, which I think is really important right now. And if you work in a hospital like mine, administrators and so forth are paid if they fill beds, right? So they're incentivized to get people in and get people out. And so everyone's sort of working in this volume-based environment, churn environment, instead of sort of focusing on good health outcomes. Well, there are actually ways, creative ways, that we can incentivize doctors like me and Kelly to do good care rather than do a large volume of care. And so I'm working on something called global budgets, where we would pay a hospital like Hennepin County Medical Center a flat rate for caring for their community for the span of a year. They wouldn't get more or less if they saw more or less people, but they would get bonuses or incentives if they improved community quality metrics like racial disparities in birth outcomes or vaccination rates or tobacco smoking rates, things that we actually know help our community to be healthier. So I'm going to be working on that and hopefully have the support of you, Addie.
Yeah. Count me in as a co-author on that already. Yes.
Yeah, right. Exactly. I know you want to go on to the next question, but I love that idea. And I think that it's so important that we talk about the way that providers and hospitals are reimbursed, this whole fee for service where there's this incentive to do things to people. The most important thing that most doctors can do is talk to patients, is to educate them about their health and how to live healthy lives. And there's no reimbursement for that. And that's a major flaw. And it sounds like you're starting to get at that, Dr. Klein. I love it.
Yeah, absolutely. And we had a couple questions come in the chat. One is very relevant, asking, what are your top healthcare priorities for the next legislative session? The regular session, I'll say. I know specials are getting not so special anymore. Yeah.
Yeah, well, I think it's my turn to go first. My top one actually is this global budgeting idea. They're doing it in Maryland. I've had a good reception when I brought it up with actual hospital systems. They seem pretty interested in it. They'd actually rather try to operate on a budget rather than count on, sort of volume and churn. I've had good reception when I've talked to patients, obviously. So I think it's going to be an exciting idea. The other big thing we have to get done is some further regulation of drug pricing in the state of Minnesota and across our country. Dr. Morrison has been a chief author on some of those initiatives, and we've made some steps, but we certainly have a long way to go. The sort of profit basis for pharmaceutical industry does create miracle drugs, and we're fortunate for that. But once you've created those miracle drugs, you have a moral obligation as a society to make sure they're available to Minnesotans. And we need the government to be that mediator, to find that common ground so that people can get access to the drugs they need. Insulin was really just kind of an icon for what is a bigger problem. Once you've sort of fixed that problem with insulin, which we've started to fix, don't you have the same obligation to fix a problem with epileptic medications or seizure medications or antibiotics? All of these medicines are sort of life-sustaining, and you can't sort of adjudicate them just on income or means alone.
Mm-hmm.
Two of my big priorities in the last session in the context of our divided legislature, again, the only divided legislature in the country, not a great distinction in many ways, but perhaps some people think that that's, keeps a check on one party or another. But in the context of that, I did get my drug price transparency bill signed into law, collaborating with Senator Julie Rosen, who's a Republican in the Senate, as well as the reform of the prior authorization process. And those are the Drug Price Transparency Act, both are compromise bills, as any bipartisan bill must be. But I think that the Drug Price Transparency Act will provide important information for policymakers and the public as we look at how we tackle the cost of prescription drugs. And then the reform of the prior authorization process, hopefully, will decrease administrative burden for providers and frustration and access for patients. So I was proud to get those across the finish line, but I'm very interested in learning more about Dr. Klein's initiative. And then, of course, as an OBGYN, maternal health is a passion of mine. And we have, you mentioned it, Matt, we have some of the worst disparities when it comes to maternal morbidity and mortality and infant mortality. Black and American Indian women in Minnesota die at 3 to 4 times the rate of their white counterparts from pregnancy-related causes in our state. We have overall some of the lowest infant mortality and maternal mortality, but when you tease it out by race, we're not doing well at all. In fact, we're one of the worst. And so that is a embarrassment for our state and a stain on our record and wrong. And so that is a priority of mine. I've been working with Ruth Richardson, my colleague in the House, on a bill called the Dignity in Childbirth Act that tries to get at just that. It increases the use of doulas, which have been shown in good studies to help women have better outcomes. And it also adds severe maternal morbidity to our maternal mortality studies so that we study those near misses, women who became very sick, who needed blood transfusions or were admitted to the intensive care unit before, during, or just after their pregnancies, hoping that that can help us get to the root cause of some of these disparities. And then I'm also, I authored a bill this past year that there was no appetite in the Senate for, which is to extend MA for a year postpartum. Currently, our parents who have children, who have babies in Minnesota are kicked off medical assistance at 60 days postpartum. And in the context of an opioid epidemic, a mental health crisis, and the disparities that exist, that's unacceptable. For new families to get off to a great start, women need to have access to insurance and care in that first year. I could go on and have a lot of other ideas, but those are my big priorities.
I want to just jump in on racial disparities in health outcomes, if that's okay, Addie. I'm
Yeah.
not getting too far off track.
Yeah, no.
You know, it's just exploded. Obviously, so racial disparities in American health outcomes have been present since the birth of our nation. But when I went to medical school at Mayo in the 90s, it never came up once. It wasn't the subject of a medical school lecture. I was actually completely unaware of it. Recently, thankfully, due to the advocacy of, thoughtful physicians, it's come to the fore that people of color have much worse health outcomes in every sense than white people in our country. And that's true even if you adjust for socioeconomic status. So it's not a function of being poor or being destitute, it's just a function of the color of your skin. And people say, well, how could that be? That seems kind of mysterious, doesn't it? And so I tried to examine, I guess, in my own response to why there are these significant racial disparities in outcomes. One is this thing, that we call systemic racism, which clearly does exist in the healthcare delivery system. And the way I describe it is, if I had two identical patients on my shift, a 45-year-old African-American woman from North Minneapolis with abdominal pain, and a 45-year-old white woman from Minnetonka with abdominal pain, and they came in, I can imagine in my mind that their experience of passing through the emergency department would be quite different. The validation that they would have for their pain, the rapidity with which they would be treated, the studies that would be ordered, the follow-up plan that would be ordered. And then after discharge, their access to sort of healthcare follow-up, to nutritional support, to stable housing and so forth would be very different. And so that's part of the problem, I think. The second part of the problem is that the medical community has been unethical in the past in its treatment of people of color, most famously with an experiment called the Tuskegee experiment, where African-American men in Alabama were not told, but they were not treated for their syphilis. They were treated with a placebo for their syphilis so that doctors could discover over years how syphilis progressed. Studies like that, which were blatantly racist and unethical, have created a suspicion within communities of color about what kind of care they're going to get when they go to seek health care. So a suspicion of Western medicine. And so we need to sort of attack both of those problems, systemic racism in our delivery and suspicion within communities of color, before we can solve the disparities problem.
Absolutely. Thank you. Yeah. So Kelly, our mutual friend Dan asked a question. I'm sure you'll be happy to answer. So with September being Suicide Prevention Month, what steps can we take at a local level to mitigate the horrible 16 to 22 veteran suicides per day? What have you learned in your careers in healthcare and/or politics that could help with the suicide epidemic for veterans?
Well, I assume you're referring to our mutual friend, Dan Kessler, who is running for the Minnesota State House and is a psychologist, which would be a tremendous addition in our citizen legislature. If you believe in that concept where people with different backgrounds and different skill sets come together to make policy, he would be an outstanding addition. great individual, wonderful psychologist, and running a heck of a campaign. And he brings up an important issue, and one that is near and dear to me. My husband is a former Army Ranger and a combat veteran, and my father-in-law is a disabled veteran after his second tour in Vietnam. So the well-being and health of veterans is critically important to me. And we're failing our veterans on many levels. We're asking them to do way more than any human being should be asked to do. So many of our soldiers have done multiple tours over the past decade or two. And the toll that takes on them and their families is insurmountable in some cases. So we have to make sure that veterans have the access to the mental health care that they need. We need to be doing everything we can to destigmatize the challenges around mental health. The distinction between mental and physical health is an arbitrary one. They are one and the same. And I liken it in some ways. It's not perfectly analogous, but we have some of it in medicine as well. That there is sort of this macho culture of, I can stay up for 2 nights in a row and take care of people with grievous injuries or frightening illnesses, et cetera, et cetera. And I'm not burned out, and this doesn't impact me because I'm tough. And I think soldiers have some of that, and their culture also has some of that in the military. And so we need leadership in the military who is willing to recognize that and work to change it.
Yeah, I couldn't answer it any better than that. I will say that sort of mental health parity has been an issue ever since the great Senator Wellstone began talking about how we treat mental illness differently in our society, both in terms of culturally, how we approach people with mental illness, how we talk about their disease in a stigmatizing way, and how we personally are secretive with our own mental illness issues. But also, of course, the financing mechanisms for people to seek out and pursue mental health treatments. What has happened, tragically, is that we've absorbed mental health care into our penal system, our prison system, and into our schools. 2 areas that are uniquely poorly equipped to handle this serious problem. So instead of the medical community caring for people as we should, it's being picked up by the correctional system in schools. And so we've got to get a robust and equitable system of mental health care in our country.
And one other thought, Addie, if I can just interject, is, some of us have tried to talk about the silver linings of the pandemic, and there are some. And one may be the increase in the use of telehealth. And I think that's an area that can be really helpful when we talk about mental health, because it provides privacy, particularly if someone is feeling some sense of shame or embarrassment about reaching out for help, to be able to get care within the privacy of their own home. I think is a really important development. It will help save healthcare costs, and it potentially will save lives. So that's an exciting development.
Definitely. I'm very vocal about my mental health journey, and then I go to therapy every week, and I think it's great, and I think everyone should. Yeah, definitely made that a big part of my platform as well, to expand our mental health services into rural areas, schools, police forces, but rolling that into any healthcare plan would be a great first step. So
I would love to hear Dan Kessler's answer to that question too. I wish he could jump on.
Yeah, I'm gonna do another town hall with him too.
Good.
We'll probably talk about that a lot too.
Excellent.
Yeah, he's cool. So our other mutual friend, Hunter Cantrell, came on and asked a question that is kind of leading into our next topic. How can we increase access to prescription drugs and make health insurance more affordable? Is a Minnesota Care buy-in option one of the ways we can expand access? And on that note, does that expansion affect pay for care providers?
Well, there's a lot of questions wrapped into there. You talked about the pharmaceuticals and the Minnesota Care option, and how much doctors end up earning. So let me start with the Minnesota Care public option. So in case your listeners don't know what that is, so Minnesota Care is a platform that's already available to working low-income Minnesotans, a small subsegment of our population who do not have insurance through their employer and do not have medical assistance. They have the option of going to the state and buying an insurance product, a health insurance product, at a cost that is sort of graded to what their income can afford. And so it's affordable, and we also know that it's effective. So it's we know that it's good coverage, it provides basic care, provides critical care, and so forth. And it's a good product, and it's self-sustaining. So we would like to, the vision has been that why shouldn't every Minnesotan, why shouldn't Addie Miller be able to buy Minnesota Care, and Dr. Morrison? And it would sort of give you some liberation from sort of the shackles of being tied to your employer insurance. So it would foster the market in that way. And also it's just a good healthcare product that would improve the public health of our state. It's had opposition from the insurance industry. Another competitor in the market is always problematic, but it is a good and fair way. And I've pushed it, I was the chief author on, Governor Walz's One Care proposal last session, and which is a version of the Minnesota Care public option. And I'll continue to push it. I will say with the crisis of the pandemic and the surging unemployment in our state and in our nation, all sorts of thoughts that I had previously about employer-based insurance have been shifted a little bit. And I think it may be a time where we need to get a little more ambitious and a little more thoughtful about how we provide health care to every Minnesotan and every American. And the old models may not be adequate to the time.
Yeah, I agree with all of your thoughts. One thing I would add, and I said in the beginning, I am absolutely for trying the Minnesota Care buy-in as a public option as a way to increase competition, expand access, and address affordability. I also, with the information that we will get from the Drug Price Transparency Act, which asks actually requires pharmaceutical manufacturers to report to the Commissioner of Health the reasons why they priced a drug, when a new drug that comes on the market above a certain threshold, or an existing drug or a newly acquired drug, why it increases by a certain percentage over a 12 and 24-month period. So we're gonna be able to gain a lot of information about why that's happening and force pharmaceutical companies to justify some of the outrageous, frankly, pricing of some of their medicines, life-saving medicines. So to me, it's unethical. We all saw this with the story of Alex Smith the past 2 years after he died, when he had to ration the insulin that he needed to live. Unacceptable, because he couldn't afford it. That shouldn't happen in Minnesota. It shouldn't happen in the United States of America, in my view. So one idea that I authored last year, there was not much appetite for hearing it in the Senate. Interestingly, your predecessor, Addie, was the chief author in the Senate, which to me shows the urgency with which we need to address the cost of prescription drugs. This is not a partisan issue. This is a human issue. So this bill would create a drug price affordability commission. So there would be an independent board that would examine drugs that are exorbitantly priced and set a maximum reimbursement threshold for ones that are out of control. So that would be one way where, as Matt said, things have reached a point where we need to try new things. The pharmaceutical industry has created miraculous drugs, has done many amazing things, come up with a lot of innovations, and it also is essentially unregulated, and there's no there are very few incentives for them to have true competition.
Yeah, and just to jump in on that, Addie, that sometimes, so often people say, well, why are drugs so much cheaper if you go to Canada or if you go to Italy or something? Why are they cheaper? And the truth is that's been studied, and it's because those countries have been willing to do things exactly like what Dr. Morrison is authoring, a drug affordability commission. They've been willing to regulate and interfere on behalf of their citizenry to control drug prices. And we have not. And that's sort of in the nature, I guess, maybe of the entrepreneurial environment we have in America, but it's time that we make sure people have access to the drugs they need.
Yeah, absolutely. So we touched a little bit on the Alex Smith Emergency Insulin Act, and I know a lot of the folks that are watching probably know a little bit about that, but can we talk a little bit about what the roadblocks were to passing something like that, and did that end bill go far enough?
I mean, I think the answer is a pretty short and simple one. The pharmaceutical industry came full bore against it and almost succeeded in preventing its passage. They have big incentive to prevent things like that from happening. And that was pretty unconscionable. My understanding was there was kind of an agreement, a verbal agreement that they were not going to, that we had reached a compromise that they were able to live with. And then they filed a lawsuit immediately upon its coming into effect. And I think they kind of showed their true colors in that moment. It's not okay. And so the big pharmaceutical industry holds disproportionate power in our state and at the federal level. And this can lead us down another campaign finance reform conversation, but their impact is disproportionate and outsized.
You know, I've always been surprised. If in my simplistic view of sort of marketing in America, I feel like the drug companies should have the best public image of any company out there. I mean, they make these miraculous drugs. We can cure, in some cases, lung cancer now, which we couldn't 20 years ago, and that's due to their innovation. And yet they perpetually destroy this image with this sort of craven profiteering. Insulin is cheap to make, and making sure that it was available to young Minnesotans so that those Minnesotans didn't die just seems to me to be a good corporate investment, if not an ethical mandate. And so I'm not sure why they have fought the Alex Smith Insulin Affordability Act tooth and nail. I think it's disastrous public policy, and it just hurts what should be a good reputation of a good industry. But that's who we're dealing with. And when we have hearings at the Capitol on things like this bill, drug affordability, or anything that impacts the pharmaceutical industry, they won't send their representatives to come testify or answer questions or give their perspective. They're really fairly dismissive of the power of government. And that's, because they know they can hire lobbyists sort of in the ninth hour and shut down legislation. So it's going to take Addie Miller winning a seat to the Senate to sort of empower us to combat their authority. So.
Well, I am more than happy to do that. More than happy to do it.
She's ready.
Yeah. We had another question, a kind of a follow-up to the suicide question we'll touch on real quick before we move on, asking if how effective red flag laws would be in a mental health crisis kind of situation. Would that help with the suicide rate at all?
I think you're up, but I can't remember.
Sorry, I think it is me. Yeah, no, I think it's too bad we don't have our good colleague Ruth Richardson here, who's so most knowledgeable. So she's my House representative, and she's an attorney, and she's the author in the House of the red flag laws. And she's done all the research on how they've been effective in other states. They have passed in Republican-led states, and people that you might not suspect have actually advocated for them because they know first of all, I guess I should explain to your listeners what a red flag law is. A red flag law allows, if you have a loved one or a family member or someone in crisis who you believe has the potential for suicidality or homicidality or harm to themselves or others, you can request the court to serve an injunction to remove the firearms from your own home. And after a hearing of sorts, they will issue that, and that'll be the red flag. And then those guns are removed from a potentially suicidal or homicidal individual. And again, it's gotten the support of law enforcement. It's gotten the support of veterans, and it's been proven to be effective in other states. It's a humane intervention, and I'm an author on the bill. So.
I'm also an author on that bill in the House. And I think, the two gun violence prevention measures that were addressed last year, universal criminal background checks and red flag laws, really do fall under the category of common sense gun violence prevention legislation. And I think you summarized it well, Matt. That's been shown to make a difference in other states. When we talk about gun violence in America, a large portion of that is death by suicide by gun. And so that has to be taken seriously. We have a mental health crisis. We have rising suicide rates, not just in the veterans community. And this is a common sense way to keep our families and our loved ones safe. I also think it has a role in terms of education. It provokes conversation. It educates the public about the realities of gun violence in our country. I don't think it demonizes guns the way I think it is portrayed by some people. Look, I think in all of our districts, we have law-abiding, smart gun owners, hunters. This is about protecting people. This is not about taking people's guns away.
Definitely. Yep. One other question before we move on to COVID topics are, there was yesterday on NPR, there was news of an ongoing concern due to vaping activity on our youth. Should Minnesota take additional steps, including taking flavored tobacco off the shelves and investing in youth tobacco prevention? And what else do you think we should do to address this epidemic?
Yes, I think the latest that I read is that our vaping rates actually are starting to decline, which is a very wonderful development. It is incredibly addictive. It is a nicotine delivery device, and we've seen a generation of young people get hooked on nicotine. So I think the education that has been occurring, the scare with some of the very serious consequences that some people unfortunately have befallen them, have created an environment where people are starting to stay away from them. Having said that, the fruit flavored kinds of vaping products are very purposefully directed at getting children hooked. And we can't just stand by and be okay with that. And so I am for taking those off the shelf, doing everything we can to keep them away from minors. And I did author a piece of legislation to fund youth tobacco product prevention public service.
Yeah, and this is where, so I have an interesting perspective on tobacco policy in general. It's where a little bit of my libertarian streak comes out. I think people do have the right to make bad health choices and drive a motorcycle if they want and eat a Big Mac and smoke a cigarette if they're so inclined. Where I get very offended, though, is by the repeated efforts of the tobacco industry to target young underage individuals, which they've done in every generation and every year with pretty good success. And it's only been good public policy that has sort of each time beaten back that success. And of course, we saw it most recently with the advent of vaping and the flavors, where all of a sudden youth nicotine use was exploding compared to what it had just been 5 years ago. So just a tremendous marketing success by the industry and clearly targeted at our young people. And I do think that's unethical marketing and requires sort of a government intervention to counter it. So we are going to continue to work on sort of banning flavors and so forth. We are going to continue to work on a pod tax because we know that the youth market is particularly sensitive to financial incentives in terms of purchases of tobacco products. So a $2 per pod tax on each vaping product. And we're going to use those proceeds, if we are able to pass that law, to continue public education efforts on tobacco.
Great. Yep. Sign me up for that one too. So everyone who is watching that's local knows that the Chaska Herald does a candidate questionnaire every year, or every candidate cycle. And I was filling mine out, and they said, what are your top 3 issues that you want to tackle when you get to the legislature? And I listed my top 3, and I said, but overarching is getting us out of this pandemic, both health-wise and economically, making sure that we can be as whole as possible and as safe as possible. And I think everything that we do in the next cycle and the cycle after that probably is going to be somehow related to this global pandemic. So on that topic, how do you both feel that the state's COVID-19 response has been in terms of protecting frontline workers and the general public?
Yeah, well, and so what's telling about that is that we know it can be done from the experience of other countries. We actually know that you can salvage your economy and you can preserve public health. But it takes leadership at every level, and it particularly takes federal leadership with a unified voice and leading us into what's going to be some sort of common sacrifice. In the absence of that federal leadership in our state, Governor Walz did the very, very best that he could, and the numbers bear that out. And he had a graded shutdown, and it generated enormous political opposition and was gradually sort of drawn back. And what we've been left with is sort of this continuing simmering fire of COVID, where we have about the same number of cases and same number of deaths steady over the last month currently. And that's, I guess, on some level a success. It's better than having a huge peak and having our intensive care units overwhelmed, but we can certainly do better. Again, we know from the experience of other areas that better can be done, but it's going to take a sense of shared sacrifice, and it's going to take solid leadership.
I couldn't have said it better. We had a botched federal response, to be quite frank, and we've learned more about that in recent days, that unfortunately the president understood the risk and downplayed it. This was such a leadership opportunity and an opportunity to save probably tens of thousands of American lives. But in the breach, the states had to step up, and Governor Walz, thank goodness, made policy based on expertise and public health. And I think he's done an outstanding job of bringing people along, exhaustively explaining how he came to a lot of the decisions that he's come to, along with his, Jan Malcolm's done a tremendous job as Commissioner of Health. And then working with the Department of Education to come up with, I think they landed on a really good plan in terms of giving some flexibility to districts for what makes the most sense at that moment in their district, and prioritizing younger children being in person and older kids tending more toward a hybrid or distance learning, based on the information that we have so far. There is still so much that we do not know about this virus. We're learning as we go, and we have to stay flexible and open-minded. I just watched a documentary the other day called The Social Dilemma about the impact of social media on all of us. And I would encourage everyone to watch it and to consider any new opinion or perspective that you have gotten from social media. Look more closely, look at the sources. All of us have to keep open minds. These Facebook and YouTube and Twitter have algorithms that we're being used and manipulated. And it's so important that we look at each other as fellow human beings, as fellow Minnesotans. We have to be in this together because we are in it together. We don't have a choice. So let's set the partisan swords down and lock arms at a distance and get through this together. But I agree with you, Addie, the number one priority has to be managing COVID-19.
Mm-hmm. Mm-hmm. And the longer we're not addressing that as aggressively as we could be, the longer this is going to go on. So this, constant battle that we're having every special session of when are we going to end the peacetime emergency and the powers and all that, that's going to keep going on, into the foreseeable future. So there's been a lot of talk specifically in our county about the story behind reporting of COVID-19 deaths and the data modeling. So why is it so detrimental to have someone in positions of power, kind of downplaying the virus or sowing kind of uncertainty in the data and the modeling?
I think I had a glitch there. You froze for a minute. I missed a lot of that. I think about data modeling and the reporting of deaths of COVID. Is that what the question is?
Yeah,
Sorry.
Exactly. Yeah, sorry. Bad internet over here. Sorry.
No, ditto here. I forget who's first. Am I up, Matt?
You are, but since you had the glitch, I can jump in if you want. So yeah, we have had leaders who sort of questioned really every aspect of this in a surprising way, whether death certificates were actually valid, and whether PPE were being used appropriately, and whether hospitals were sort of using this as an opportunity to profiteer. And those are not only ludicrous in every way. Doctors like Kelly and I don't have time to falsify death certificates and wouldn't have the incentive to do so even if we wanted to. So they're defensive to me personally as a healthcare worker, and they're hugely detrimental to our efforts to get our state and our country to take this seriously and act collectively to get us out of this thing. And I don't know why they're out there. Maybe it is part of that social scenario that Dr. Morrison was talking about, where these conspiracy theories kind of find their traction and foothold on the internet and then never let go. And I've tried to combat them as calmly as I possibly could. The president, it was revealed last week, knew in February and March of this year 3 things. He knew this was an airborne virus. He knew that it was much more severe than the influenza virus. And he knew that it affected all ages, not just the elderly, but young people too. And yet we've spent the subsequent 4 special sessions sort of debating those very points with some legislators standing up and saying this is all a hoax and this is nothing serious and let's get back to work. And those are just not helpful comments. It's certainly not leadership, and it's not going to get our people healthy. And as a result, it's not going to help us get back to work and back to school.
Yeah, I don't have much to add to that other than we have lost almost 200,000 American lives. And that's a fact. That is the reality. Talk to any intensive care unit doctor in now pretty much any state in the union, and they will tell you this is not made up. It's ridiculous that we even need to have this conversation right now. We need to, again, set partisanship aside. This is our challenge. This is the moment we need to stand up and meet together, and to have leadership that is trying to divide us at a moment that it doesn't make any sense to me. And it hurts my American heart, honestly. So again, let's link arms at a distance and fight this together. Let's not fight each other.
Mm-hmm. Absolutely. One of the representatives, I think Friday, kind of made a blunder, a huge blunder, and sent out an email, I think intended for his own caucus, that actually went to the opposite caucus, saying that COVID wasn't a winning issue and they shouldn't talk about it and they should talk about public safety. And that was so atrocious to me for so many reasons. But just like you said, I mean, this is not a partisan issue. We're all in this together because we have to be. And I know this community. I grew up here. I know that we stand up for each other. We band together when we need to. And this is the time when we need to. So you're absolutely right. And I think, that's half the reason why I'm running, is to rise above all that partisan bickering and get people, together and working again. And that's a perfect example of why I'm running. So, all right. So what is next for us as a state, as far as getting COVID under control, getting out of the pandemic? What's our kind of next steps? And then someone asked about a vaccine as well. So if you know anything about that, feel free to share.
I think next steps, again, it's this: people are sick of the virus and sick of hearing about it and sick of living through it. But if you think back, it's been far less than a year that we've been dealing with this brand new novel coronavirus. And we need to kind of buckle down and hunker in and be ready for this to be around for a little bit longer. I think many people have done an amazing job of adjusting the way they live. And then there are a lot of people who are doing an incredible job continuing to put their lives on the line so that society can continue to function, so that food is delivered to people, so that we have law enforcement and fire and EMTs helping us, and we have nurses and doctors and hospital staff functioning. But we need to continue to social distance. We need to just get in the habit of wearing a mask when we're in indoor public spaces, and we need to wash our hands. Those are the big things that we need to do to get the virus under control. And unless and until we do, we don't have any chance of an economic recovery. If we want our businesses to be open and to thrive, we need to keep this virus at bay. Maybe I'll let you answer the vaccine one if you want, Matt.
Sure, I'm glad to. Yeah, and I think so. Recently, Dr. Michael Osterholm, who's this Center for Infectious Disease Policy president at the University of Minnesota, and Neil Kashkari, who's the president of the Federal Reserve Bank of Minneapolis, published sort of a joint editorial to how to save both our public health and our economic health from COVID-19. It was in the Star Tribune. And what they actually recommended was a new national shutdown, much more stringent than the one we've had so far, where everybody stays at home for a full 6 weeks and leaves home only for food or for health care. And they felt that that was the only way to sort of get people back into school safely and get industry operating again safely and so forth. The countervailing opinion would be, do we just sort of allow what we have currently, this sort of low burn of morbidity and mortality working its way through our society, where some businesses can open safely and others can't at all, and schools are going to be touch and go, and just kind of play that game until the vaccine comes? That's really going to be a presidential decision. I think, Joe Biden has suggested that he's looking more at a shutdown type approach to sort of reboot this thing. And I would support that. Vaccine, as far as I'm hearing, obviously multiple world players, both in the pharmaceutical industry and in academic medicine, are pursuing it. I'm hearing the best estimates is that it'll be late 2020 versus early 2021, that a safe and effective vaccine will be available. There was going to be a Health Partners participating trial with AstraZeneca in Minnesota, where they were going to recruit 1,500 people for a level 3 vaccine test. And then that study was shut down because they had a bad outcome. Someone got transverse myelitis, which is sort of this immune attack of your spinal cord. And so they shut the study down. It's good news, actually, that they were responsible enough to shut that down and not try to rush it through in advance of any sort of political agenda, so that once we actually get a vaccine, we can trust that it's safe and distribute it faithfully. It's unfortunate that this, like the other things you've mentioned, Addie, is being politicized, and the president, I think, wants to get a vaccine out before the election. I don't think that's a safe sort of approach to this, and hopefully we can continue to be responsible about it.
Yeah, I thought that article written by Kashkari and Osterholm was very interesting, because here you have a very well-respected expert in infectious disease who comes from our very own University of Minnesota and has become a national go-to person on the virus. And Neil Kashkari, who's the president of our Federal Reserve here in Minneapolis, who ran as a Republican for governor in California. So we have people with expert in economics, expert in infectious disease. I don't know what Dr. Osterholm's political sway is. I don't think that he has any interest in it right now. I think he's interested in keeping our people safe and healthy. The fact that the two of them called for a 6-week national lockdown was pretty compelling to me. I thought that was very interesting. And I loved how politics had nothing to do with it. They were dealing with the facts as we know them.
Absolutely. Yeah. I breezed over that. I need to go back and read that article more in depth. Yeah. So with our last couple minutes, I just want to say thank you to both of you. And there's a lot of thank yous in the comments as well for joining us for this conversation. We could talk about healthcare policy and COVID for hours and hours and hours, and I'm sure we will get to do that in the next session coming up. So thank you both for joining us and enlightening us. And I'm really excited to get to the legislature and work with you both. What I'm hearing is that there is a path forward. We can fix this massive healthcare problem. It's going to take a lot of work and a lot of good bipartisan work and, putting your head down and getting the work done, which those of you who know me know that I'm ready to do it. So excited to tackle this with you guys. Just a reminder for everyone, early voting starts in 5 days. 5 days. So if you live in Kelly's district, Matt's district, my district, and you have not requested your mail-in ballot yet or made your vote plan, please do that today. Get in touch with my team if you need help with that. And we do have a phone bank today at 4:00 if anyone wants to join. So, all right. Well, thanks both of you for joining, and I'm sure we'll talk to you soon. And thanks everyone for watching.
Thank you, Addie. And I want to thank you so much for running. I think that Matt and I both know what a tremendous sacrifice it is to do it, and to have a smart young child of Carver running for this seat is just the best. And get after it, girl. We're proud of you and excited. And thank you so much for running to represent your community.
So much, and not just running, but running the right way, talking for a full hour on a Sunday afternoon about issues and the health of your community. God bless you. There's not enough of that at the legislature, and we've saved you a seat on the Senate floor right next to mine.
I can't wait. Can't wait. Let's do it. All right. Have a great rest of your day.
Thanks so much for having us.
Thank you.